you're all doing well. We would like to welcome you to our session today, Oxygen Therapy in Critical Care, the case-based series. This is session 6. Just to go through a few of the housekeeping items, as you can see, we'll be using the chat function for question and answer at the bottom of the screen. Please send our question through the chat box. Feel free to introduce yourself. If you have any IT issues, you can send a message through the chat. And also remember that the session is being recorded and your attendance is consent to be recorded. If you will have any audio problems, you can try to one of the tips as is shown on the screen. So to begin with, my name is Kevin Raphael. I'm Pharmacist International. I'm going to be sharing the items in the chat and also sharing my screen for the presentation. With me, the host for our session today, we have Ico India team. We have Rahul, Zoya, Durba, and Upendra with us. And we have Dr. Datti, who is our hub director. And I will now hand over to Dr. Datti to take us through the introduction of the other panelists so that we can begin the session. Welcome, Dr.
Datti. Thank you very much, Kevin. Once again, you are all welcome to session number 6 of our Oxygen Therapy and Critical Care case-based series. Today we'll be talking about basic intensive care unit care considerations. And as usual, I have excellent 4 panelists. We have Dr. Salim Ibrahim Abdullah from Bauchi. You have Irene Aronison Ahidenu from Irua, Edo State, Nigeria. You have Dr. Henry Embu. I don't know if you have joined us from Jos University Teaching Hospital. And we have Hassan Alimaina from Federal Medical Center, Yola, Adamawa State. So once again, you're welcome. So the discussion for today is basic ICU care considerations. Okay, sorry, there was a slight glitch. All right, so today we'll be discussing a case of Mr. T, a 46-year-old man that presents with hypoxemia or respiratory distress. So but before we get to that, we'd like to look at what we need to learn from this discussion to change the way we practice in our various settings, in spite of the various limitations we will have. We are aware that the facilities, the capacity of facilities change from one area to another. So in the practice change objectives, we need to try to identify the minimum standards of an intensive care unit that can be applied across board. And then in that, we need to identify the key healthcare providers in an intensive care unit. We need to also try to discuss the types of monitors needed in an ICU. We need to list the specialized equipment needed in an ICU. The second change objective, major change is we need to be able to list the most common indications for ICU admission. This is very important. And then we have to understand and prevent. The emphasis is prevention. Prevent the most common complications that occur in ICU patients. And then we need to be able to review or develop and implement ICU care bundles. That is the type that can work in your settings or your ICU. Okay, so let us start. This is a case of Mr. T. He's a 46-year-old male with history of obesity, type 2 diabetes mellitus, and type 2 diabetes mellitus, who presents to the emergency department after 3 days of shortness of breath, cough, and fever. An examination showed that he appears well, his breathing is non-labored, he's not in distress, and he is speaking in full sentences. Past surgical trials, laparoscopic cholecystectomy in 2012. He had no smoke, he doesn't smoke, doesn't drink, and he's not on any drugs. Lives with multiple family members, works in an office as a water engineer. His vitals were heart rate of 98, blood pressure 127/63, respiratory rate slightly on the high side, but we told he's not labeled, it's 30 cycles per minute, and his temperature is 36.5 degrees Celsius. However, his SpO2, that's saturation, using pulse oximetry was 87%. So the plan is placed on a non-rebreather mask at 10 liters per minute, and his saturation improves to 93%. The emergency room physician places a call to the on-call ICU physician. This is typical in most of our settings. So now I want to draw your attention that you can see 10 liter anyway. So we need to look at what is an ICU. And then we can now have a discussion. You can see the various things from this chart here: patient management, monitoring, organ support, nursing care, and so on. If you look at it quickly, indications and what you need to do. So because Irene may have to leave us in an hour or less, we try to use our expertise now. Irene, I now call on you to take on the discussion from here in this section. Hello, Irene.
Yes, thank you, Dr. Datti. Thank you. So we're going to, this just is more like what people think ICU is. Is it a place for monitoring, organ support? Is where you have life-threatening diseases are managed, nursing care, patient-centered, vital signs. So I think in our own centers, we can decide what is an ICU, what do we feel an ICU, what do the surgeons feel the ICU is for, what do the patients need to be. And I'm sure in our different centers where we practice, we have, some feel the ICU is where, once you get to the ICU, you don't recover. So feel even if you're on end stage, you will get to the ICU, recover, But I think this just helps us to understand today's discussion on exactly what an ICU is going to be like. If my internet, my video, so it makes it better. Thank you. Okay. Can we go down? So critical care is a more, so we have ICU, have an ICU, every teaching hospital, secondary care hospital should have, and what is change action for this segment is to identify the minimum standards of an intensive care unit. This is because some of us here may be called upon to, we need to start up an ICU. The hospital is green, you don't have an ICU. Has said an ICU is an organized system for the provision of care to critical and specialized medical and nursing care, and enhanced capacity for monitoring and multiple modalities of physiological organ support to sustain life during a period of life-threatening organ system insufficiency. Nursing care, there's an enhanced capacity for monitoring, then modalities for organ support, And this part is important. It sustains life during the period of life-threatening organ insufficiency. So ICU actually just helps to provide that window for see if the patient can bounce back to their pre-morbid status. Usually in ICU, we don't do, but we just try and see how we can use modalities to sustain and all key points with the equipment. Complications are, you know, is it what life-threatening organ system is there? So we'll now go to the follow.
Sorry, I can't hear from this end. Again, I
can't.
don't know if it's the same with.
Yeah, we can't hear as well. I think Dr. Irene's network is not stable.
Maybe Irene is. Maybe perhaps.
I'm going to stop my video.
Oh, okay, great. Yes, that will help. Thank you.
Yeah, I've turned off the video. I think that will help. So I was wondering if we had
I think, Irene, we still cannot hear you now.
sincere apologies.
It's okay. It's not your fault. Is it better now?
Okay. Can you hear me now?
Much better. It can improve. We can't hear again now.
I'm so, it seemed okay. Yes, I've tried to talk. Okay, so
maybe I would suggest maybe if Salim's connection is much better, or Hassan, if he can take over from there, and then when it improves, you can come back to Irene. Is your own good? Okay. Okay, what about Dr. Salim? Let's try from your end.
Good afternoon, all.
Okay, so Salim will take over from here while we later on, if she will come in again and Hassan will follow. So carry on, Salim, please.
Okay.
Thank you.
We had about the definition of ICU, because it's a specialized unit that is staff with specialized staffs with trained capabilities to manage the critical care patients. So now we have the question, which of the following are standard components of an intensive care unit? Participant can answer this in the chat box. Which of the following are standard components of an intensive care unit? 1, continuous monitoring. 2, specialty trained healthcare providers. 3, system for delivery of time critical care. 4, specialized patient care equipment. That's 4. 5, rapid access to diagnostics and therapeutics. Then 6, all of the above. Okay, the answers are coming. Okay, that is very good. All the responses are for all of the above. Yes, indeed. That's what differentiates care in the main ward and in the ICU. That is continuous monitoring of patients, so that every bit to bit you're monitoring the patient. Any deterioration will be picked early, and then intervention will be instituted. That is why the care is time bound. At any moment you discover an anomaly, you try to rectify where with the problem and then intervene. Yes, and for you to achieve this, you need specially trained healthcare providers, and then you need specialized equipment for continuous monitoring of the patients. And then, of course, rapid access to diagnostic and therapeutics, because it is time bound. So any moment a problem is sensed, then it should be diagnosed, and then therapy instituted. So let's go down.
I think there is we may have a resource there, either a video or this thing that can further illustrate this thing.
Okay, let's go. Okay, is this a video?
It is not a video.
No, it's not.
Okay. Okay.
Reference to all these professional groups that have given summary, certainly to ask you professors at different parts of the world where you can get additional information on what is an ICU here. So this is the information, right? Okay.
So now the next thing is practice change action item. That is to identify the key healthcare providers in an intensive care unit. So we have a case update. Despite the 10 liters per minute of oxygen by non-rebreather max, Mr. T's SpO2 decreases to 89%. Initially, it has improved to 92%. So now it has decreased to 89%, and his respiratory rate increases to 32. It increases from 30, it has increases to 32. He is only speaking 2 to 3 words at a time. So does this patient need the ICU? If yes, why? And then why or why not? So it's a question of yes or no. Does this patient requires ICU? But remember, if you answer yes, you must state the reason, and then also the reason for no. Okay, so a lot so far from the respondents, the answer is yes. So let's discuss. Click. Okay, somebody say he will need ventilatory support. Okay, so let's have additional information on the question discussed. Yes, somebody say he has respiratory failure, respiratory rate of 32 cycles per minute, is tachypnic and desaturating. Okay, all these there are reasons. Yes. Okay. So can we please click on discuss?
No, there is no resource there. It's just to
Okay, there's
discuss.
no resource there. Okay. All right. So we have seen the reasons now that this patient requires ICU. So which of the following are essential stuff for an ICU? 1, ICU trained nurses. 2, ICU trained physicians. 3, respiratory therapists and physiotherapists. 4, pharmacists. 5, cleaning stroke.
I think you have janitors, the cleaning staff.
Okay, cleaning
They
staff.
have attendants, cleaners, yeah.
Attendants.
Janitorial staff.
Yeah.
Okay. And then 6, all of the above. Can we have the answers? Was one of the most important resources for intensive care unit are staff that are specially trained in caring for the critically ill patients. So which of the category of patients are required to man the ICU? Okay, majority of the respondents are for all of the above. Yes, because the critical care team is a multidisciplinary one. So you need the ICU trained nurses, the ICU trained physicians, the respiratory therapists and physiotherapists. You need the pharmacists, you need cleaning, janitorial staff, and then in some cases, even the administrators to keep the record of the ICU. So the ICU runs under the direction of the medical director, who usually should be a physician that is trained and certified in critical care medicine. But in our own case, because of our peculiar challenges of the critical care trained physicians, mostly the anesthetists are serving the function. So the director is responsible for overseeing all aspects of the ICU, as well as supervising and facilitating other staff members toward the patient care. The medical director should have a full-time commitment to the functioning of the ICU, including scheduling other staff or other physicians with at least one ICU specialist for the unit at all the time. He or she also ensures appropriate education program in place, because there should be training and retraining for optimal patient care. So therefore, we need all the following, all the above staff to effectively run an ICU. Okay, thank you.
Okay, thank you, Dr. Salim. Let us click and see what resources we have to illustrate all this further. So you can see the resources you can download on the minimum standards for intensive care units and try to adapt it to your settings. So you can find this is all free on the Learning Resource Center. Okay, you can see nursing staff, other staff, you can see all those information, the educational, just like what Salim was trying to explain. Okay, You also have structure of an ICU, siting, design, and so on. And then you look at your environment and you try to adapt it. If you're in a position, managerial position, this will be helpful for you if you want to submit a proposal to your management to get an ICU. Okay, let's go back to the main discussion. Okay, so let's scroll down and see. So you can see this is a schema. You have the staff, it is very important. Let's go down. So which of the above providers, the list of those staff components, which of the above providers could improve the care of Mr. T? How can they be involved and why? So to help us guide us through this discussion, let me call on Dr. Hassan Mena Ali, if your audio is clear.
Yes, I'm available.
Okay, great.
Yes,
so carry on with this question. It's still a follow-up question on the list of the staff that will be involved in ICU care.
Okay, good evening all from over here. Please, can we scroll up? Can we scroll up? Yes, so these are the list of staff that are needed to improve patient care. In reality, all of them will improve the care of the patient in the ICU in different capacities. Now, number one, we have ICU trained nurses. And in the ICU, as we are going to see later, there is a number of nurses to patient ratio. And the nurses are the ones on ground to detect problems in the patients and alert the physicians and even make some interventions on the patients. So the ICU trained nurses are very, very important in the ICU for patient care. Number two is ICU trained physicians. The physicians are the overseers of the ICU, and they are the ultimate people that make guided interventions based on the experience and the expertise. They control and they make interventions on the patients to improve the patient care. And the third category is the respiratory therapist and the physiotherapist. The respiratory therapists are very important too in ICU because you have patients that are not breathing well or are not breathing at all, and they are on, some of them on mechanical ventilation. And as we can see, even if they are not on mechanical ventilation, they are on some sort of oxygen therapy. And the respiratory muscles are not in use. So the respiratory therapists are very important in this aspect because there may be collection of secretions, and this is where respiratory therapists and the physiotherapists are important in this aspect. The physiotherapists are also important because the patients are usually not mobile. And because they are not mobile, there is some kind of muscle atrophy and muscle weakness, muscle pains, and those the physiotherapists are very important in preventing this sequelae in ICU. The fourth category is the pharmacist. The pharmacists are also important in the ICU because the ICU patients usually are given different types of drugs from different specialties. Since the ICU care is a multidisciplinary care, you have different teams of doctors coming to see the patient, and different medications are given for different problems in the patient. So the pharmacists are very important. They are supposed to be versed in drug-drug interactions and doses of drugs that are specific for patients in ICU. And the next category is the cleaning staff, because you have different interventions being done on the patients. They have secretions, they cannot control their bowel, cannot control their bladder. You have different types of waste that is produced in the ICU. And it is supposed to be very, very, very clean to prevent nosocomial infections. And this is where the cleaning staff and janitorial staff come in. So all these people, like we said, all of the above, are all important in the management of the ICU patients. Thank you.
Thank you very much, Hassan. Let me add here is that, let me draw your attention to the fact that the list of the staff is saying essential, meaning that there are still other staff that can still contribute to the management of the patient in the ICU. For example, you can have nutritionists, because nutrition in the ICU, nutrition in the critically ill patient is very important. And you also have the laboratory staff that can assist. Some ICU, most ICU have a side lab, or you have a laboratory that is sited close to the ICU, so you also need their support. So apart from the essential staff, you have other important staff. So it's all teamwork. Let us scroll down, please. Now, I have a case update here of Mr. T. Now, Mr. T, like you rightly said, will require further care in the ICU. So Mr. T is finally transferred from the emergency department to the ICU after evaluation by the ICU physician, which in most of our settings, if you are in a teaching hospital, it will be a resident doctor or a consultant anesthetist. He's placed in an isolation room with negative pressure as a person under investigation, which is PUI, for COVID-19. We remember we are still in COVID times. He continues oxygen therapy with the non-rebreather mask, but the flow has been increased to 15 liters per minute. Now, I want you to remember our other sessions where we talk about oxygen therapy and the devices, and then the flow rates, the range. If you remember the non-rebreather mask, you will require up to 15 liters. So it has been escalated to see what happens. So the question here, which monitors should be placed on this patient? We need to discuss that. So let me call Dr. Embo. Harry, are you with us and you're clear? Is clear?
Hello, good afternoon, Dr.
Okay.
Datti and everybody. Yes.
Okay. So guide us through this discussion. Which monitor should be placed on this patient, and then the question that follows and for the participants. Thank you.
Okay, so the question there now is, which monitor should be placed on this patient? We have a resource.
Type into the chat box what they know,
Yes.
and let's see what they have.
So we're waiting for responses. Which monitors? Somebody's typing in nasal catheter. That is not really used for monitoring. So what we want, what response we are looking for is monitor. Okay, ECG electrodes, pulse oximeter, pulse oximeter, pulse oximeter, non-invasive blood pressure, ECG, pulse oximeter, capnograph. Okay, so we have, okay, somebody, temperature, good. So temperature. Will require a lot of monitoring. The problem, his issues initially are mainly from respiratory. So it will be good to monitor the pulse oximetry, the peripheral oxygen saturation, and respiratory rates will be nice to have in this patient. But it will also be good to monitor other systems. Like many of you correctly also indicated, ECG, heart rate, and blood pressure. They're all correct, all right on this patient. Temperature too, I saw. Very, very right. So all this because you are managing this patient as a whole. So it will be very important to see what is happening to this patient in total. I don't know whether this discussion, there's a resource attached to this. Dr. Datti, is there a resource?
No, there isn't a resource.
No, there is just
Okay.
to discuss. I think we tried to explain, for example, those dimension pulse oximetry, why we remember why do you have to use pulse oximeter. Remember, this patient is hypoxemic and is worsening, and that's why he's in ICU. And then probably the pulse oximeter will now determine when to further escalate the oxygen therapy, which will not be limited only to invasive therapy with the intubation. Some already mentioned mechanical ventilation in the beginning. And then the blood pressure people dimension, of course, you need to ensure that this patient's circulation is okay. And somebody even mentioned urine output. You need to ensure that you remember the organs are being treated, so you need to make sure that homeostasis is maintained as much as possible.
Okay, thank you so much. There's a question that follows. Which of the following is not a patient monitoring requirement found in ICUs? So we have 6 options there. Number 1, we have electrocardiogram. Number 2, pulse oximetry. Number 3, arterial blood pressure. Number 4, transcranial Doppler. Number 5, respiratory rate. Number 6, none of the above are required. So the question is, which of the following is not a patient monitoring requirement found in most ICUs? So responses are already coming in. Some are indicating 6 number 6, which is saying none of the above are required. Some responses are number 4, transcranial Doppler. Okay, so I think for me, the essential phrase there is saying most ICUs. So which of the following is not a patient monitoring requirement found in most ICUs? So if you look at electrocardiogram, it is essential. We see that in most ICUs to monitor the electrical activities of the heart. The pulse oximetry too is very essential in the ICU to monitor oxygenation in the ICU, and it's found in most ICUs. Arterial blood pressure, invasive and non-invasive, is very, very important in ICU. When you consider transcranial Doppler, that is a form of monitoring that you may not find in most ICUs. May find them in just that is not widely used in ICUs. So if you, in my opinion, transcranial Doppler is not commonly found in most ICUs, but respiratory rate is also a a parameter that should be monitored by most ICUs. So I don't know, I think there's a resource attached to this. So, okay. It's talking about basic monitoring for seriously ill patients. And we see here the heart rate, the blood pressure, the respiratory rate, pulse oximetry, and other things like hourly urine, temperature, blood gases. So these are some of the commonly monitored parameters you'll find in the ICUs. So, and which are some of the things we saw in the options that we saw earlier on. So yes, and I think this resource too can be available for the participants. So I think.
Yeah, thank you very much,
okay.
Henry. Like you just said, on the chat box, the link to this very, very important article is there. You can download, you can always access it through this link. If you're taking notes and so on, this will be helpful. You can see the basic monitoring requirements, all the things we mentioned, including early urine output and so on, blood gases are there, but that transcranial Doppler is not most common in most ICUs. So let's go back to the.
Yes.
Okay. So I have a case update here, and I would like Irene to take us through the discussion. The vitals now, at this point, you have a heart rate of 102, blood pressure of 117/52 millimeters of mercury, respiratory rate is 32, temperature 37.5 degrees Celsius, it has gone up a bit. And then the saturation has just slightly improved at 15 liters. So we're still not there. So Irene, there is a question there that we need to discuss there with the participants. If you're okay, because I'm calling you in because you say you may be leaving for an important meeting in the next 15 minutes or so. So let's try and see if we can get your insight.
Okay, we have this patient who is still tachycardic, tachypneic. What other, in addition to patient monitors, what other types of monitors are needed in the ICU? This is a generic question. In addition to patient monitors, what other types? So we can actually write a lot here. So if we could put it in our chat box, this is a discussion question. Thank you. So what other types of monitors? So it's, based on how rich the center is, or if you have a lot of grants, have collaborations, what other types of monitors are needed in the ICU? Okay, we've had ABG, yes. This isn't what, a lot of centers might not have this arterial blood gas, yes. Which other monitor? For this, we can think, like in a developed or a highly resourced center. Okay. ABG. So I think with this question, we're not looking at particularly this patient who is a patient under investigation for COVID. We're just talking in ICs, what other types of monitors? Yes, thank you. Intracranial pressure. Since in IC, you get to deal a lot with patients with head trauma or some form of encephalopathy. Status epilepticus. Echo, yes. Especially patients who come and are in failure and requiring vasopressor support. Thank you. Keep them coming. EEG for patients with seizure, protracted seizure, status epilepticus, or some form of encephalopathy. Thank you so much. Okay, CTG, if we have a parturient for continuous monitoring of the fetus. That's a good one, thank you. So we've got a lot of responses. Arterial blood gas monitoring, which could be the handheld iStat, or the ABG analyzer, which is much larger. Intracranial pressure monitoring for patients with raised ICP. Echo, usually transthoracic, but of course, if you need, then transesophageal is more specific. We've talked about transcranial Doppler, EEG, CTG. We also have glucometers, because that also helps to monitor. Then for our patients who are intubated, it's always good to have the cough manometer. That helps us to monitor the cough pressures, so we do not cause tracheal stenosis. I know a lot of us do not have that in our centers, usually just inflate, but thinking, if we want to have things there, a cough will be good. A cough manometer, that will be good for even patients with a tracheostomy. Of course, monitoring airway pressures are one of those monitoring components of ventilated patients, or even patients who are, as long as they're connected to the ventilator, you can have a lot of monitoring from the ventilator on cough pressures, inspiratory pressures, peak plateau pressures, and even compliance. But that's usually when patients are connected to the ventilator, either breathing spontaneously or some degree of control or completely controlled. There's also something that we should also monitor in the ICU, which is noise. It's not something we usually do but we have to realize that ICU can be noisy at times, especially when we have open ward ICUs. So there are these noise decibels that should actually be put in. I've probably seen only in one ICU, but it's something to think about, because we know noise affects patients' sleep and circadian rhythm. So noise monitoring is also something that could be monitored. I don't know, if there's anything to be added, Dr. Datti, on this? Because this is more of it.
Yeah, thank you very much, Irene. I wanted to say that we have all left glucometer, but finally you mentioned that. Even though the question is general, but then we can remember the index case we're discussing as type 2 diabetes. So that is also important to monitor frequently in the ICU. Let's scroll down. I think we have lots to discuss more, so we can with the time. So you can see bedside nurse standard patient monitors is just telling you these are the other things that we need to consider. Monitoring of the equipment, monitoring for patient transport. These are also important. What is the recommended maximum nurse to patient ratio for critically ill patients in the ICU? Usually you have this recommended ratio for optimum care of the patient. So this is a question maybe I should call on Hassan once again to guide us through this. And I think there is also a resource material attached to this to help to assist us. Thank you.
Okay, good evening once again. So we have this question: what is the recommended maximum nurse to patient ratio for critically ill patients in the ICU? Like I mentioned earlier, that we're going to see it later in the presentation. So there are questions. Can we get some answers from the participants in the chat box? Thank you. So we have 1 to 1. More answers? Yes, 1 to 2, 4, 1 to 2. Yes. Yes. Okay. Okay. We're having 1 to 1. 1 to 2. 2 to 1. Wow. That's 2 nurses to 1 patient. Okay. 1 to 2. Okay. So we are having multiple responses, and the majority are saying 1 to 2. Okay. 1 to 3. I don't think Dr. Irene is supposed to comment here. Okay.
Sorry, I was just trying to increase the responses.
Okay. Okay, thank you. So we have 4 options. 1 is to 4, 1 is to 5, 1 is to 3, and 1 is to 2. But actually, there is no specific number generally. It all depends on the level of the ICU. And you know, all ICUs are different depending on the staff, the equipment, the personnel, and the location. So, but we have a link here. So let's open it. We're going to see the different levels. Yes, so we can see here that we have 3 levels of ICU and a normal ward at the bottom. So if we take the level 3 ICU, where we have the type of patients, then the ratio, then the interventions that are done in such ICUs. Now in level 3 ICU, the type of patients that we get are critically ill patients who need hourly or invasive monitoring. So when we say invasive monitoring, we are monitoring things like arterial blood pressure, invasive arterial blood pressure, which measures the blood pressure beat to beat. So such as continuous blood pressure, monitoring via an arterial cannula, yes. So the nurse patient ratio in such level 3 ICUs is 1 to 1, and highest is 1 to 2. That's why they said 1 to 1 to less than or equals to 1 to 2. So the highest is 1 to 2 in such level 3 ICUs. So on the right hand side, you can see the interventions that can be done in such ICUs, but that's not the case here that we are discussing. So in the level 2 ICU, that is the intermediate medical unit, the type of patients that we see are unstable patients who need nursing interventions and then monitoring for in intervals of 2 to 4 hours. And you can see the highest nursing to patient ratio is less than or equals to 1 to 3. So it means 1 nurse to 3 patients is the highest in such ICUs. Then the level 3, in the level 1 ICU, is the lowest ICU that are found in districts. So we have stable patients there who need close ECG monitoring for non-malignant arrhythmias or laboratory work every 2 to 4 hours. So the highest number of patients to nurses is 1 is to 4. You can see it is written less than or equals to 1 is to 4. So when you go to the ward, this is the one at the lower bottom. You have stable patients who need testing at least 4 hourly. And you can see the ratio is highest of 1 is to 5. So less than or equals to 1 is to 5. If you can get less than 5, it is that less than or equals to means you can get less than 5 is fine, but the highest that you are supposed to get is 1 is to 5. And on the right side are all interventions that are done in such a level of wards. Thank you.
Yeah, thank you very much, Hassan. Let me still emphasize on this resource that you shown on the screen. You can see whatever patient you have will be managed in any of these categories of care. From the ward to the level 3 ICU. The level 3 ICU you find in most developed countries or well-equipped centers. And then, of course, it's capital intensive. So you choose the one that works for you. And this is so important that you can look at your staffing and then decide the kind of ICU you will run. Most of our ICUs now hover between the level 2 and level 1. And then you go back to the ward. So this is important, and the link has been shared on the chat box. You can always refer to it, download or print out for your reference. And all these are there on the Learning Resource Center for free. Let's go to the main discussion, please. Right. So let's scroll down. So the next thing, the practice change action item that we want to be able to list the specialized equipment needed in intensive care units. Now, which of the following specialized equipment is least likely needed in the care of our patient, Mr. T? So let me call on Dr. Salim to guide us through this, please. Salim.
Thank you. So we have a question which says, which of the following specialized equipment is least likely needed in the care of Mr. T? So this question is very specific. It's directed to the care of Mr. T. One, we have airway equipment. Two, mechanical ventilator. Three, manual ventilation, masks and bags. Four, external ventricular drain. And then five, suction apparatus. So, okay, the answers are coming. So far, okay, four, yes, that's very good. Four, that is external ventricular drain. Yes, because Mr. T has respiratory symptoms, so definitely he needs monitoring airway equipment, airway equipment monitors. Then mechanical ventilation, because he's already, his saturation is on oxygen therapy. And in fact, the 15 liters per minute, where no rebreather, and then 3, manual is certainly needed. What is not needed for Mr. T is the external ventricular drain, which is mostly for patients with raised intracranial pressure. Okay, suction apparatus, yes, you can have situations that needs to be suctioned out. So what is not needed for him is 4, external ventricular drain. Okay, can we scroll down? Okay, so now we have another question. So what other specialized equipment is common and helpful in the care of ICU patients? So this is a general question.
Sorry, Dr. Salim.
Sir?
Sorry, before you move on to that, let me just explain further on the on the airway equipment. I want the participant to always remember the previous sessions on the oxygen therapy to link with the case here being discussed. Remember that this patient was brought into the ICU, or rather Mr. T was brought into the ICU with a non-rebreather bag, which was even escalated from 10 liters per minute to 15 liters per minute, and yet we are getting 91%, which is not our goal. So the further escalation will be now invasive oxygen therapy, which they all rightly said that this patient will need airway equipment, mechanical ventilator, which will need intubation and so on. And then the suction apparatus, of course, you have to clear the airway so that you can improve on the oxygenation. So this much our participants should remember. So far, they are doing very well. Thank you. You may continue, please.
Okay. So do you have a question, a general question? What other specialized equipment is common and helpful in the care of ICU patients? So this is for all patients being managed in the ICU. So what other specialized equipment is common? So we can respond via the chat box. There is no response yet. ABG. Okay, somebody said AED. So far, only 3 answers. 1 ABG, pulse oximeter, AED, ECG. Okay. You also remember defibrillator in the ICU. For transport equipment, infusion pumps, syringe pumps, weighing equipment. Yes, the list is very long. Airway pressure monitors. So we have a link for resource. So let's see. Okay. This is a document, a reference document on the minimum standard for intensive care unit. It talk about the minimum equipment required, the staffing, and everything about the design of ICU. So it's a very resourceful material. We should all download it and have a check on what it contains. It's a very long document, 14 pages. Talks about everything in ICU, from equipment, staffing, and then even the levels of care. So it's a very detailed equipment. We should all download it and look at it. All right.
Thank you very much,
The
Dr.
link has
Salim.
been shared.
Yeah. Yeah, thank you very much, Dr. Salim. That document is very important. Let us all try to get a copy of it from the Learning Resource Center. Now we go to indications for ICU admission in general. And then we should be able, at the end of this, to be able to list the most common indications for ICU admissions. So we have questions and also a link for resource there. So I will call on Henry to guide us through this quickly. Henry, are you with us?
Okay.
Yeah.
Good afternoon once again, everybody. All right, so indications for ICU admission. So the practice change action item. It says list the most common indications for ICU admission. Okay. And says, what are the most common indications for ICU admissions? So we'll be waiting for responses. You can type your responses on the chat box so that we can go through them once again. Okay, we're still waiting for responses. Okay, they are coming. I think some have started coming in. Is it? No, not yet. Okay. Critically ill patients in shock, unconsciousness, critical care. Okay. These are some of the responses we're getting. We'll still be waiting to get more responses. Unconsciousness, okay. Close monitoring. Severe tetanus, GCS less than 9. Trauma. Post-op patients without respiratory effort. Stroke, okay. We've gotten quite a number of responses from the participants. Organ support. Okay, I think there's a resource, so we can go in, click on the resource and see what respiratory compromise, okay? Good. All right, so we have this resource on critical care statistics. So can we scroll down this, talking about cost of critical care, possible cost savings? Can we scroll down and see? Okay, all right, so well, it has some issues on critical care patients and so on, but then we know majorly patients come into the ICU for either to receive some close monitoring, which a form of monitoring that is not available in the traditional ward, a high level of monitoring and care, and also for organ support that will require maybe support for one or more organ systems. Those are generally the broad reasons, categories, reasons why patients are admitted into the ICU. Can we go back to our, okay. So I'm sure the link to this resource will also be available to you. So patients generally, like Mr. T, the index patients we're talking about has issues with respiratory system. So the reason why he is coming into the ICU is for respiratory support, which is an organ support and close monitoring of the respiratory system. So there could be other systems that are involved, which could be cardiovascular, it could be central nervous system, it could be renal and so on. And so those can be reasons for, and you can break down into many of these examples that were given by our participants on the chat box could fit into that, some of these reasons. So
yes, they mentioned quite a number that fits into what I saw on that article under the critical care patients. In the body of the text, in the sections, you will see the examples being given US statistics. They're all there: cardiac arrhythmias, gastrointestinal hemorrhage, and so on. And I've seen the chart box Irene added obstetric hemorrhage, sepsis, and so on. So it's quite a number of them. Let's move on because we're running short of time. We've got just about 15 minutes. Let's scroll down, please. So here you have the ICU admission, discharge, and triage guidelines. You have a framework to enhance critical operation development of institutional policies and further research. So you can, this is a guide for you when you want to set up your own ICU according to your resources. Let's scroll down, please. So now this is also very important. We have an important component of this session, common complications in the ICU. And what we need to change in our practice at the end of this discussion is to understand and prevent. The emphasis is on prevention. Prevent the most common complications that occur in ICU patients. Now, the case update here to illustrate this, still we go back to our patient. Mr. T is now beginning to look obviously fatigued. He is less awake. He has labored breathing now, and his color is looking more dusky, or rather cyanotic. He's asking for help to breathe. The vitals posted were a heart rate of 102. Blood pressure has started to drop. 97/51. Respiratory rate has gone up from about 30 to 37 now. Temperature is a bit high, 37.5 degrees Celsius, and saturations 87 has dropped from 91, 87%. So so let's scroll down, and if Irene is still with us, you can guide us through this, the next step on Mr. T, the discussion.
I'm still here. So what clinical steps should be taken for Mr. T? Could you just scroll up a bit, please? Thank you. So he's asking, he's becoming fatigued, so he's getting tired, less awake. So that way, there's hypoxia, which is affecting his CNS, labored breathing, dusky, asking for help to breathe. And when you're asking for help, means we have to intervene. Blood pressure is dropping, heart rate is increasing, and his SpO2 is 87, and he's reached the max of 15 liters per minute. So the next thing is, do we have time for responses in the chat box, or just go ahead? No time.
Yeah, you can give like 30 seconds for people to type.
So 30 seconds, so could you just type in, because we really have a lot to finish up. What is the next step? What clinical steps should be taken to care for Mr. T? He's hypoxic. He's becoming hypotensive. His level of consciousness will start deteriorating because he's fatigued. He's less awake. Anything in the chat box? Any responses? Well, we don't have any response, so I'll just go ahead. If they come in while I'm talking, we can answer. So for Mr. T, we need to intervene. Yes, we have invasive mechanical ventilation, intubate and place on SIMV mode. Thank you. So that's it. Now, because he's fatigued and less awake, we really can't, we would have escalated to using a non-invasive, but he's less awake, so he'll probably not cooperate with the non-invasive, or probably not have an improvement. So the next thing is to actually intubate, secure the airway, and connect him to a mechanical ventilator, and see how we can support him and allow him rest a bit while we try to readjust the respiratory parameters. Of course, once we do that, we have to connect him and decide a lot of things, what our FR2 will be, and what mode. We could place on SIMV mode, we could do a control. It all depends on how much effort he's making, pressure support or volume support. Of course, we'll still have all our monitors in there. Of course, an arterial line would be nice. That would give us a bit by bit blood pressure, and also help us in assessing how well our ventilation is and how well we can adjust our parameters for the best for him. We'll remember to put our filters in, because he's still a patient under suspicion for COVID.
Yeah, thank you very much. Quickly, we go down to the update on the patient. Now, as the ICU team attempts to place Mr. T on oxygen therapy by high flow nasal cannula, he loses consciousness. After successful intubation, he is placed on a mechanical ventilator, which according to all your responses. He is now hemodynamically stable under sedation. Next, the ICU team decided to place a urinary catheter and an internal jugular central line for increased venous access. Lab draws, that is, you take samples for investigations and monitoring of central venous pressures. So we have a case discussion here, which we want Dr. Salim to guide us through this one. Please quickly, 2 minutes. Dr. Salim, if you are with us. Okay. Okay, maybe Dr. Hassan, can you come in?
Yes, sir.
Okay, please. Thank you.
Okay. The question says list some common complications that occur with ICU care. Is a discussion. So can we scroll down, sir, to the diagram below? So this diagram gives a pictorial representation of some of the complications that may occur in the ICU. And since we have only 2 minutes, I'm going to just go over it. This VAP is ventilator-associated pneumonia, and happens when patients are intubated or usually for mechanical ventilation. When the tubes last longer in the trachea, there is a risk of ventilator-associated pneumonia. That's an infection of the respiratory tract. Then this CLA-BSI is a central line associated bloodstream infection. So since central line is inserted to this patient, there is the possibility of nosocomial infection from that line. The presence of the line there gives that susceptibility to infection.
You can leave.
Okay, so the next diagram we see is that of Dvt and Pe, which is deep venous thrombosis and pulmonary embolism, which is precipitated mainly in the ICU by immobility in the patients, and which some other diseases that the patients have can also precipitate the patients to the Dvt and Pe. For example, this patient has diabetes mellitus, which is a strong etiology for deep venous thrombosis. The next one is antibiotic resistance, because the patients are usually on 1 or 2 or more antibiotics, and the organisms are usually most susceptible to resistance than in the other wards, since they don't have that antibiotic administration like in the ICU. We also have COTI or CAUTI, which is catheter-associated urinary tract infection, which happens when patients urinary urethral catheters are passed for the patients. The catheters are conduits for urinary tract infections. The next one is over-sedation, because if the patient is in ICU, and especially when the patient is being ventilated, the patients are usually sedated to prevent fighting the endotracheal tube. So sometimes they may be over-sedation, which also has its own disadvantages. We also have malnutrition. Some patients cannot take orally. Some cannot. In some places, we don't even have the parenteral nutrition, and then the NG tubes are passed. Sometimes you cannot get the adequate balance of the food that is necessary for the patient, so you have malnutrition in patients. Then PICS, which is post-intensive care syndrome, which is going to be discussed later. We have medication errors, because different teams come and give different prescriptions, and then the drugs are given at regular intervals, in which there may be errors in giving those medications. There is delirium, which is a psychiatric disorder. It's because of the patients are usually in the ICU, all this noise, they don't have their relatives close to them, they have all these gadgets making beeps, and all these gadgets in their throats, in their bladders. So all these factors cause all those delirium and the rest. Then we have stress ulcers, because the patient is also in stress, and some of them are not even feeding orally. Maybe they may be on total control nutrition. They may have stress ulcers in the gastrointestinal tract. Then organ dysfunction, which also may occur in the ICU because of the condition of the patient, or even from the interventions that are being done to the patient. But these are supposed to be prevented. Thank you very much.
Thank you very much, Hassan. As you can see, the complications can be prevented, and we should know that as the care is becoming more invasive, you will be faced with these challenges or complications, which we can minimize. Let's scroll down quickly. The next thing you have care bundles, the different types of packages that you can have in IC when you want to develop your own IC. You have to choose the bundle that will work for you. And the practice change here is to review or develop and implement ICU care bundles for your ICU. Let us quickly click, because we don't have time, we see what kind of bundles are available as a reference. So when you go still to that great article, you want to see the kind of bundles that is available that you can adapt to your settings. It's taking time to, okay. So you have this, you can see it's titled Nursing Made Incredibly Easy. So understanding care bundles, you can have all the reference you need here to help you plan in your own setting. No matter how small you have, at least you have the means to monitor pulse oximeter, non-invasive blood pressure monitoring. You can have a bundle that suits you. So you have them. Okay, let's go back to the main. So there are, then you can have the link there on the chat box also. So he's talking about central line associated bloodstream infections. Also, you can have, there are steps to prevent such from occurring or to minimize it. And this is available also on the Learning Resource Center. You can see wash your hands, wear sterile gloves, hard mask, and so on. The standard infection prevention control. And you can, now let's go down. Again, the catheter-associated urinary tract infection, you can see how you can minimize this complication from occurring, because they will increase morbidity and mortality in the end if you don't tackle this. Let's scroll down, please. Again, sepsis and septic shock. Also, you have a bundle that you can also use to minimize the occurrence. We're really running short of time. Okay, let's go down. So all this, you can refer to this to assist you. Okay, so and then what is PICS? We can click and see what we have there. So so this is a post-intensive care syndrome. And the post-intensive care syndrome is made up of health problems that remain after critical illness. You should know that your patients in the ICU, when you finally stabilize them and they're out of the ICU, they can develop this post-intensive care syndrome, which is comprised of health problems that remain after the critical illness. So you have this great article to review. Some of you that ICU acquired weakness, you know, and you have some statistics here that 3% of all patients on ventilators, 50% of all patients admitted with severe infection, up to 50% of patients who stay in the ICU for at least 1 week. So all this we should be, and then you have cognitive or brain dysfunction. Okay, let's go back to the main thing, presentation, please. Okay, here we have a video. I don't know how short it is. Let's look at the short video, please.
Dr. Datti, is the sound audible?
I can't hear. The sound is not audible here. Will you want to try from another source? If you have, I can. Is audible now? Okay, I think we can move on because the video is available for us anytime, or you want, okay, let's see if there's, the audio is, okay.
Many people now survive critical illness. Healthcare professionals used to assume that patients who survived critical illnesses returned to how they were before. However, stories of patients with profound struggles after being hospitalized emerged, such as James, Maria's, and Ping's stories. James was a businessman. He had sepsis from a severe bout of pneumonia and needed life support for 10 days. For months after his illness, he was forgetful, had difficulty concentrating, and frequently lost his train of thought. James was asked to copy this drawing, and he drew this. Maria was a professor. She had severe influenza. Her kidneys and lungs failed, meaning that she needed dialysis and a breathing machine for 2 weeks. After her hospitalization, Maria had profound weakness. She had to learn to walk again at a rehabilitation center. Ping was in 4th grade when he was hit by a car. After being in the intensive care unit, or ICU, he went to a rehabilitation hospital. Ping talked little at rehab, but learned how to use his arms and legs again. He had a hard time reconnecting with his friends. During the past 20 years, research has confirmed that these types of stories happen more often than not. In 2010, the Society of Critical Care Medicine, or SCCM, gathered together experts involved in the care of ICU survivors. The group named the combination of problems common to survivors of critical illness post-intensive care syndrome, or PICS. PICS includes new challenges to the brain, body, and emotions, and is seen in more than half of critical illness survivors. Children surviving critical illness often have similar problems, such as delayed developmental milestones, learning problems, and sadness. Families and friends are also affected. For example, James' persistent problems led to his wife giving up her job to be his caregiver. Researchers are working to prevent and treat PICS. SCCM believes that ICU survivors can share their stories to help each other, which is why its Thrive initiative is building a network of face-to-face groups for critical illness survivors. In 2015, 6 Thrive sites were launched. In 2016 and 2017, even more will join. If critical illness has touched you or a loved one, please join us. Let's create a better recovery together. More resources about PICS and the Thrive initiative can be found here.
Yeah, thank you very much. That video is very revealing of what is happening now. They're emerging things now, even after a recovery from critical illness. So you have other things like ICU Liberation Bundle, A to F, which you have them, you can go through them. You assess, you assess, prevent, and manage pain. Then the B, you have both continuously awakening trials and spontaneous breathing trials, and so on up to F. So you have all these things available to you. Let's scroll down because now to review the topics that we went through today is quite a very large topic that each aspect of it we can have discussion for hours. Now, an ICU is a separate hospital unit staffed by specially trained physicians and nurses who work closely with other specialized staff to care for for patients. And we've seen using the case of Mr. T. The ICU patients need intense monitoring and support for failing organ system, which all participants agreed from their answers in the chat box. And then ICUs require specialized continuous patient monitoring systems. ICUs require specialized life supporting equipment. And then we need to also be aware of the indications for ICU admission and the differences depending upon resource availability. This is very important. And then critically ill patients in the ICU can suffer several complications that must be prevented and monitored. And you have care bundles that can decrease ICU complications. You just choose the bundles that will work for your environment. Then there is also a post-ICU syndrome, which is emerging, and then it's something that you have to also be aware of and plan for it. Because now there is more because of improving care and then access to knowledge like this one we are doing has led to increase in ICU survivors, and then you have to now deal with this syndrome. And then the PICS also affects the patient's families. This we should know. We've all seen that. Now, institutions should follow the guidelines for ICU liberation as well. And then the implementation. This is a code that many smart learners can recognize a situation, evaluate a situation, and even decide what should be done. It is a competent learner who takes action. An exceptional learner improves their practice and finds unique solutions despite systemic barriers. So let's scroll down, please. So the practice change here, the situation under it, you have the critical care and ICU care support patient with life-threatening illness or injury, and so on, up to the care bundles that can decrease some complication. Then you need to be able to evaluate, you compare, identify, and then you look at the bundles again. Let's scroll down, please. And then you take a decision, and then you take action. Let's go down, please. Can we scroll down, see what we have remaining?
That is the end.
Okay, great. I want to have my closing reminder that we've all gone through what we should know about basic ICU considerations, no matter our settings. And then you have the levels of care that you can choose. If you don't have an ICU, don't be deterred by the equipment that are listed there. Whatever you have, from pulse oximeter to whatever you have, all you need is the protocol and start, and you can escalate. And then we should be aware of the complications, and then we can prevent. Thank you very much. Kevin?
Thank you. Dr. Datti, thank you so much for such a great training session. Also, thank you to all the panelists for a great session. We've reached the end of the session. I'm just going to share some few items before we close the session. Just a reminder as we close the session that you can visit the Learning Resource Center for the presentation slides and recordings. Also, as you've seen, the site includes many additional resources, quiz, case exercises, and videos. You can visit the LRC through this link. Also, links to the recording and the LRC will be shared after the session by email. You can join our community WhatsApp group by scanning this QR code here, or you can message Assist at the number that is displayed there. We thank you all for your participation And please remember to join session 7, which is going to be held on 29th of July 2021. We are going to be discussing defining acute respiratory distress syndrome. If you have any questions, you can email at equatassisinternational.org. Thank you so much. We will meet in the next session.
Thank you.